Dr. Carlos Colette, welcome to the GIS. This is the fifth edition of the GIS, and we're happy to host you with us during this our annual conference. Today, we had an interesting session about bifurcation, and we had a live case of interesting bifurcation case. Um, um, One of the main important things that we always like that people when they walk out of the session they walk with the take home messages that actually going to help them on their practice on a daily basis. So if you can summarize for us kindly what are the take home messages from the session today.
Well, thank you, Mohammed. First of all, I have to thank for inviting me for this really spectacular meeting. This is very educational from the content point of view. And the bifurcation, well, bifurcation lesions in general remains a very challenging scenario, as you know. Event rates are higher, and for that reason, I think contemporary PCI, you should consider employing all the tools that make your life easy in terms of first defining the significance of the disease, using physiology to understand if there's an indication to do PCI. And then, of course, when you have decided to undergo PCI of a bifurcation, and particular left main disease, as we saw in the session, the use of imaging is very, very helpful to understand not only where to land, but also to understand which techniques are more suited for that particular anatomy. So to answer your question, I think what I learned from that session is how useful intravascular imaging is. First, to define the type of disease. When I speak about the type of disease, I'm referring to the burden of calcium that might require lesion preparation to have a good extent expansion at the end of the procedure. I think that's one of the points that was highlighted during the transmission. And the second one, again, relates also to the use of imaging, but now not to assess the morphology of the lesion, but to optimize the treatment. And we saw a case, for example, of DK crush, where imaging was used to assess the size of the balloon to crush the stent, and finally, of course, to optimize the stent implantation. So I think it was a comprehensive session demonstrating the value of contemporary tools to optimize treatment in bifurcation lesions.
Today the discussion about which strategy of treating the bifurcation was actually an interesting discussion because there was a couple of ideas about what would be the best strategy to treat a bifurcation. Is it a mini crush? Is it a DK crush? Is it a Colette T stenting? And there are different discussion about it. What's your take home message from this?
So I think there was a very interesting discussion indeed. And what I learned from the discussion is there are many techniques might be suited for many bifurcations. And the data that we have so far actually supports the use of any of these techniques. And in my personal view, when you can finish the bifurcation with a provisional stent and a good result in the side branch, this is the preferred approach because the trials have shown that there is equivalence in outcomes. But when you have to use two stent techniques for anatomical reasons, I think that we also, the data also demonstrate that there is equivalence in technique. So I think after the discussion, what became evident to me was that you should be using the technique you're more familiar with. And if you want to, you have to choose one, select one and become a master in that technique so you can apply that confident, following the steps, and I think that will guarantee good outcomes.
How important is the imaging after the procedure?
So that's a very good point. I think that when we think about imaging, I think I have to highlight that pre-procedural imaging is crucial because you not only understand the morphology and the way that you have to modify the plaque in order to achieve an adequate extent expansion. So everything is linked, in my opinion. I think if you use imaging, of course, you have to use it before. Now, after you have implanted your stent, I think there is a lot of value because you have the chance to optimize part of the procedure that are remain to be important. For example, fix any potential malapposition, and sometimes you can really optimize extent expansion that has been shown to be the main predictor of outcomes in all the clinical trials with imaging, and now more lately with Illumin 4 that demonstrated that the only predictor of target vessel failure is stent under expansion. So I think that there is a value of imaging both before and after PCI to achieve the greatest extent expansion possible.
And where do you see the future of bifurcation therapy? Do you see it with more metal, more complex intervention, or you see it with a simpler technique a single stent and a possible other technology like DCBs?
Well, that's a fascinating question. I have seen many cases from around the world, and there, of course, there is the classical approach, which was the one that was employed during the session. There was a DK crush with, as you said, a lot of metal. We can say like that. But I think new technologies like drug coating balloons, specifically to address the disease in the side branch, are increasingly popular because the clinical outcomes appears to be similar, but the fact of not having double layer of metal or sometimes triple layer of metal in the bifurcation, I think that at the long term will be beneficial for the patient. So I do welcome these novel hybrid approaches of stent in the main vessel and throat coating balloon in the side branch. And I think, of course, we need evidence to support this claim, but I think that's the future of bifurcation PCI.
Dr. Carlos, I'd like to thank you for taking the time to be with us and coming all the way and accepting our invitation for this conference. I think we learned from you and for the contribution and being with us. Bifurcation will remain an interesting discussion. I've been doing intervention for more than 20 years, and we're still facing the same problem and talking about the same topic. Uh, but definitely, today we have a more effective tools on screening, assessing, knowing exactly what we're doing, and seeing exactly what we're doing. And I always say what we used to consider an angiography, and that's a complete setup. It's not anymore a complete setup. Cath lab has to be equipped with all imaging tool, physiological and intracoronary imaging, which is OCT and IVUS. But definitely, we have learned a lot, and from people like you, and sharing knowledge is the way we grow, and we develop ourselves and improve our practice. Thank you for being with us.
It's been a pleasure, Mohammed. Thank you for having
Thank
me.
you, Carlos.
Thank you.
Thank you.